Good morning, everyone. Today we're going to be talking about retinoblastoma. Just a brief overview of what retinoblastoma is and how we can detect it, and how we should be how we can manage it, and also take care of retinoblastoma patients. Retinoblastoma is the most common intraocular childhood tumor. It actually ranks now as the third most common among childhood malignancies, overall childhood malignancies in a registry here in Philippine General Hospital. It may involve one or both eyes. It is potentially fatal, but it is curable in 90% of cases. And the key here really is early detection. Pediatricians and general practitioners, family medicine doctors, barangay health workers are key elements in early detection for retinoblastoma. We outline here all the signs and symptoms, the frequent signs and symptoms of retinoblastoma. One is squint, inflammation, and the third is leukocoria, leukocoria being the most common. Let's talk about squint. Squint is just ocular misalignment, and this can happen in other cases, not just with retinoblastoma, but it could be a warning sign of retinoblastoma. It happens because the center of vision, which is located in the fovea, sometimes will be involved by the tumor. So if you look at the picture on the lower right-hand side, you can see the nerve on the left-hand side of the slide, and you can see a yellowish, a whitish tumor involving the center or the macula or the fovea centralis. You can see the blood vessels feeding into the tumor. In these cases, the eye tries to move on its own to try to see, to have a best view. So it tries to move a little bit, and that shows ocular misalignment. Inflammation can also be a sign of retinoblastoma. Usually, this is a later presenting sign. It can cause glaucoma or increased pressure of the eye because of tumor enlargement, the tumor taking up space inside the eye. And it can also happen because of obstruction of the normal flow of the aqueous fluid or the fluid within the front of the eye. So if you see in the upper left-hand photograph, you can see tumor cells in the anterior chamber on the front part of the eye. And this can occlude the normal flow. You see the diagram showing you the normal aqueous flow from the ciliary body, going through the pupil, going to the anterior chamber, and into this meshwork called the trabecular meshwork, which drains the fluid. If the tumor involves this meshwork, then the flow will be hampered and consequently will cause increased pressure and glaucoma. And it can also, the inflammation can also arise from direct infiltration of the ocular tissues by the tumor itself. And it can cause swelling, and as you can see in the bottom right photograph, the redness of the lids as well, and also of the eyeball. The most common symptom or sign that the parents usually bring the child to a doctor would be a white pupil. It's called leukocoria. So leukocoria by itself is white, leuko, and coria being the pupil, and it's the obscuration of the the normal red-orange reflex. If you see look at the top photograph, you see the red-orange reflex is equal for both right and left eye. But as you look at the middle photograph, you see a discrepancy between the two eyes. So the reflex is a little different. You'll see it more in the bottom photograph. You see a yellowish, pinkish hue on the left pupil as compared to that on the right side. Sometimes the parents or the caregivers will say it's on and off. Sometimes it's there, sometimes it's not, and usually they notice it at night when the light is dim, The ambient light is dim, so that is because the pupil starts to dilate, and you can see the white pupil more prominently. But as the tumor progresses, then it will be you will see the leucophoria all the time. Now, in 2005, we introduced some pediatric eye screening into the clinical practice guidelines of the Philippine Pediatric Society, and this is composed of the corneal light reflex, the red reflex test, and photo screening. Okay, we'll go into detail here. So this is just a way, this is just a way to see the corneal light reflex. You flash a flashlight, and you look at the where the light hits the eye, and you can also see this is how it's done. So you can use either an ophthalmoscope, or you can just use even just a regular pen light. So you'll see here, you see that if you can see the point of reflection of the light, you can see it in the center part of the pupil. And in cases where you see on the right, bottom right, you see the reflex in the center. It's not the same as the other side. You can also see the discrepancy of the red reflex. Sometimes patients report that they see the white pupil on photographs. And because of this, we've started on using this as a way of screening patients by taking flash photography on dim light without taking away that red, because there's an application in your camera usually that takes away the red reflex. In this way, you want to elicit the red reflex. There are different other diagnoses that may manifest with leucophoria, squint. These are retinopathy of prematurity, persistent fetal vasculature, parasitic infections, cataract, and Coats disease. These are the most frequent causes for leukocoria. But these are mostly all of these 5 are benign lesions that will not cause any problems systemically. But of course, it can affect the vision. We will not go through each one, as this is beyond the scope of our discussion. But in any case, we'll talk about the detailed history. Detailed history will show us with retinopathy of prematurity. One of the clues here would be, of course, a history of prematurity or a case of stormy delivery. You have to have a good prenatal history if you want to detect whether there was a parasitic or parasitic infection that may cause this or development of cataract. Coats disease can happen, and this is a problem with vascular abnormality, retinal vascular abnormalities. But usually this is seen in older age groups, like greater than 4 years of age. And what's important is really an extensive evaluation. And here poses the challenge for most doctors and even ophthalmologists. The most conclusive evidence, I suppose, with diagnosing retinoblastoma is the use of indirect ophthalmoscopy. Again, you see the photograph from before. The top view is showing a doctor doing indirect ophthalmoscopy. It gives you a wider view of the inside of the eye, able to see the nerve very well, the retina, and here you can see the tumor. Now, there are different characteristics of the tumor. You will see the color. It's usually yellow to white. You see the vascularity. If you see the blood vessel in the superior part, you will see it dilated as compared to the other blood vessels. And you see there's a branch that goes into the tumor and kind of disappears inside the tumor. These are feeder vessels. The retinoblastoma tumor is a very highly metabolic tumor. It needs a lot of blood supply, and if you can imagine how this tumor is like sucking up the blood. It really needs a lot of blood. Now, because it's a highly metabolic tumor, it usually kind of dies on itself, so it causes intralesional calcification within the tumor. And but it's still very active. Here we don't see the calcification just yet. because it has very good blood supply in this photograph. Now, sometimes it's very difficult to look inside, either because there's media opacity, like cataract maybe, or there's total retinal detachment, like in this case here in the photograph. You can see that the retina is now, this is an exterior photograph. You can see through a clear lens and clear cornea, you can see the retina up, very up in the detached, no? It's almost behind the lens. And you kind of suspect that it's retinoblastoma, but you can't really know by just doing your indirect ophthalmoscopy. You know, we can do a lot of other tests, like we say maybe ultrasound, CT scan, MRI, but just looking at the other eye may already give you another clue. So if we do, okay, we're just having a little technical difficulty here. There. Okay, so you can see once we dilate the other eye, you can see there's a tumor on the right eye. So this in itself can give you a clue that this could be bilateral retinoblastoma. And further tests may not be absolutely necessary to diagnose this case, but you can assume based on the photograph on the right that it could be retinoblastoma. Okay, there are different risk factors also to tell us that if it is a bilateral retinoblastoma. If the patient has a family history of retinoblastoma, certainly the patient may have bilaterality. The other thing is if the patient gets the tumor or you're found to have the tumor at less than 1 year of age, then there's a high risk for bilaterality. And so we don't just focus on the bad eye, we have to make sure that we look at the good eye as well and keep looking and following up. The other risk factor for the possibility of bilateral disease is the presence of multifocal one eye disease. So one eye having multiple tumors is a predisposition or a risk factor for having bilateral disease. So if you have a patient with one eye affected, the other eye looks still looks healthy, no tumor, but there are multiple lesions in the affected eye, you have to be careful and watch that patient, watch that better eye, and not just focus on the bad eye because of that possibility of having bilateral disease. One of the important diagnostic tools right now, because as I said earlier, it's quite difficult to do an indirect ophthalmoscopy, particularly for non-ophthalmologists. But the technology of Redcap, this is a retina camera. You'll be able to see inside using the Redcap. It's very popular now because it's being used for retinopathy of prematurity. It's a camera that if you see on the left-hand photograph, you see it's actually placed, no? It's on the eyeball, and you can actually see this is the right-hand photo is an actual image of the retina. You can see that it's even wider in field. You can see the nerve, the fovea, and you see the tumor abutting the optic nerve inferiorly. So this is a good tool. It's available in some of the centers now. I think St. Luke's has, Medical City has, and I know other centers. And because this is mostly used for retinopathy of prematurity. Now, in cases that we really are not sure and we can't see the tumor visibly by either Redcap or by ophthalmoscopy, we can use ultrasound. This is a very inexpensive way of testing. If you see in the upper hand photo, you see the dome-shaped tumor. Okay, this is the ultrasound of the eye. You can see the curvature of the eye in the back, but you see this dome-shaped tumor that is very high, with high intensity. You can see how dense it is. And behind it, you can see some shadowing because the sound waves are not able to pass through. And that is indicative of calcification. So imagine that the sound can't pass through salt, no? So it's very dense, or like bone, it can't pass through bone. So it has the same kind of consistency. Sometimes, though, you're not able to see it very well if there's this diffuse disease. Now, the other limitation of A and B scan ultrasonography is that it's not able to see behind the eye as well as other kinds of examination. But just to diagnose if it's retinoblastoma, I think this is a very good tool and inexpensive again, and available in most centers, most ophthalmic centers. Now you have CT scan, of course. You can just do a plain CT scan, and this really depicts very well the calcification that you see. You see how dense the tumor is inside the eye. In the upper right-hand photograph, you see a tumor in the left eye. You can see it very dense. The density of the calcification is just like bone. Okay, and on the middle photograph, you see bilateral disease. The good thing with CT scan is that it's able to see beyond the orbit. As you can see in the photograph in the lower right hand, you can see little bulges behind the eye, and that's already indicative of extraocular tumor, or the tumor has gone out of the eye. You can also appreciate the nerve. If you see the nerve, it's already very thickened. But the problem with CT scan, of course, especially in our setting, is the cost, access, and as well as the time spent to have this done. We have some patients that unfortunately have been asked to have CT scan, and since they come from the outlying islands, they're not able to have this done until maybe 3 or 4 months after, and that causes a big problem. MRI is very good because it does not cause any irradiation, doesn't give any radiation. It can also manifest the calcification, but not as a high intense area, but a signal void. So you see an area of black, you see the black area, and that signifies the calcification. It's very motion sensitive. Of course, the newer ones are more, it's easier, no? It's not as motion sensitive, but it still is, and that means that we need to sedate the patient. And again, cost becomes an issue, access becomes an issue, the time spent to get this done is an issue. So this can be a problem sometimes. Now you see also the benefit of an MRI as well as with the CT scan. You can also extend the scan and look at the brain. So in the photograph on your right-hand side, you can see a tumor in the pineal gland. That probably is a trilateral tumor. Okay, so a retinoblastoma tumor in the brain, which of course ultrasound will not be able to detect. Let's go to treatment. There are 3 goals now for treatment. Before, it's really just saving the life. But now we've extended it. We want to save the life foremost. We want to save vision if it's possible. And we want to save the globe even if it's not seeing. So these are the 3 goals for the treatment of retinoblastoma. First question that we always ask is, 1, do we save the globe or not? And the corollary questions is there. 1, is there hope for useful vision in the eye? And 2, if there is a risk to the life of the patient if the eye is saved. Remember, foremost goal is to save the life of the patient. There are several eye-saving techniques now available in the Philippines as well as worldwide for retinoblastoma. Primary local treatments like laser thermotherapy, argon laser treatment, cryotherapy, or freezing treatment can be done when you see the tumor quite small. No? But if it's big already, certainly we can't do this. So the limitations for primary eye-saving techniques like laser and freezing treatment is less than 4 millimeters thickness. This is quite unusual for us to catch unless the patients are children of survivors, retinoblastoma survivors, or siblings of patients that have retinoblastoma, or the other eye or the better eye of a patient with retinoblastoma. Hence, in cases that are much bigger than less than 4 millimeters in thickness, we need to use or employ chemotherapy to assist us in the local therapies. Okay, so here, let me just show you local treatment. Again, this is for small tumors. The left-hand slide shows you a small tumor in the periphery. That's a retinoblastoma tumor. You can see a tumor in the mid. Okay, and then it's treated with cryotherapy. This is using a freezing instrument. We put the freezing instrument on the freezing tip on the eyeball, and you can, while you're looking through the doing an ophthalmoscopy, you can see the freeze ball going through um, the eye into the tumor, destroying the tumor. Here in the photograph below that original tumor, you can see the scar, and without any trace of retinoblastoma tumor. Okay, this is limited for tumors in the periphery of the eye. Again, of course, the center has to have a freezing treatment facility, a cryotherapy unit, but most ophthalmic centers would have. Okay, the middle slide shows you a small tumor. It's already been treated with laser. Surrounding the tumor, this is argon treatment. And you see the residual scar. Tumor is destroyed. Okay? And you see on the last slide, this is thermotherapy. It's one kind of laser. It uses heat rather than coagulating the tumor or burning the tumor. You heat it up until the tumor dies. You see the heated up tumor, very white, and then the succeeding scar, the resultant scar after the tumor. The good thing with the laser compared to the cryotherapy is that it leaves a small scar. So in areas, particularly like here, if you see it's close to the center of vision near the fovea, then you don't want a big scar. Otherwise, vision may be affected. Okay, now, as I mentioned earlier, we're very limited in terms of using the primary local treatments because of the size of the tumor. So if the tumor is quite big, you should employ neoadjuvant chemotherapy to reduce the tumor to a size that will be amenable to treatment. And usually this is given between 6 to 12 cycles. So we give the tumor, it reduces at the maximum, the biggest reduction of 50% after the first to the second cycle of chemotherapy. Thereafter, local treatment should be started with the chemotherapy cycle. So it coincides. We do laser with the third, fourth, fifth, and sixth chemotherapy cycles. So it's a combined treatment. So we don't wait until we finish all the neoadjuvant chemotherapy. It should be given with the local treatments. So let me show you some examples. Okay, if you see the left-hand photograph, you see the big tumor abutting the optic nerve. You might still see the optic nerve there underneath the big tumor. In the past, with these kinds of tumors, there's no other recourse other than to radiate the patient or remove this eye. Okay, look at the middle photograph. You see a large tumor right on the macula or the center of the vision. So there is no other treatment. If you destroy this with the laser, or if then you would destroy the macula, or you destroy vision. If you look at the right-hand photograph, again, big tumor abutting the optic nerve. Again, other treatments will destroy the center of vision. But fortunately, in the advent of effective chemotherapy, we can reduce the tumor like this here and treat it with local treatment. We can save vision as well as the globe. Tumor here, now the fovea is saved. Patient can see very well, and the tumor is controlled. And another photograph here, yeah, you can see the fovea is also saved. So you can save both vision now and the globe and the life of the patient. But it's not very easy, no? This requires frequent examinations. During the active treatment, that means every 6 to 8 weeks of treatment, you would do an exam under anesthesia. You do the treatments, the laser and the chemotherapy. That's almost every 21 to 28 days. You can only say establish control 2 years after the last treatment if there's no other If there's no other new growth, only after 2 years will you be able to relax. But while you have control, you have to watch them, probably do exam under anesthesia at least every 3 months just to see if there are new tumors, if there's recurrences in the tumors that you've treated. So it takes a lot of logistics, takes a lot of course, finances in terms of cost, and this is not available in all centers. So we've established specialized retinoblastoma treatment centers where you can get this kind of treatment. Okay, so things to consider if you want to propose eye saving techniques. One, there is the risk of treatment abandonment. Had several patients that started off with treatment and then disappears, and that gives it, it makes it worse for the patient because they feel that the patient is responding, so they stop follow up, and before you know it, they come back with worse tumor than the first time you've seen them. Again, there's the problem of cost for treatment and follow up, especially in our country where it's mostly fee for service. Risk of tumor recurrence is a lifetime risk, and the patient has to be seen throughout his entire life. Of course, the risk becomes lower as the years go by, but I still have patients that I see, and they're even taller than I am. Well, that's not a lot of problem. That's easy to do. Okay, but anyway, so there's always that risk of recurrence. So it's a lifetime risk, and we have to watch that. Now, we have going back to the first question: is there hope for useful vision? Because if there's none, then there are other techniques that will be better for the patient. For example, like here, the anterior chamber, the front part of the eye is involved. If there's neovascular glaucoma, that will already destroy the eye. This spread of the tumor into the vitreous or the gel inside the eye. If there's widespread retinal disease, not just one tumor, but several tumors. If the tumor size is so big that even chemotherapy, even with the reduction of chemotherapy, you will still not be able to treat with local treatments, then it's best to just remove the eye. Okay, so you see the photograph, really full tumor in the upper photograph. You see the retinal detachment as I shown you before. These cases, they have to go. Okay, enucleation is the only treatment actually that has increased the survival rate from retinoblastoma throughout the years. And the goal here is to remove the tumor completely. So we have to be very careful when any ophthalmologist can do a removal of the eye, but they have to be extra careful, particularly for retinoblastoma, that they avoid puncturing the eye, avoid pressure on the globe, and also to cut a long optic nerve section, because the optic nerve is one of the passageway from the eye into the brain. So it's a route for the tumor to cross over into the brain. So you want to get a long optic nerve section. Okay, beyond enucleation, you of course will have to have a reliable pathologic study. It is very critical that your pathologist and you have a good working relationship, and that he knows exactly what you want to find out. Critical information that you need to know is if there's definite extraocular extension, and also if there are high-risk pathologic features, meaning if the tumor is at risk of going out of the eye. And of course, if it has already gone out of the eye. Because in these cases, you will need further treatment like adjuvant chemotherapy. Look at this eyeball. You can see that we did a good cut section, a long nerve, but you can see that it's bulging already. And you can see this tumor enveloping the optic nerve behind. So this is definitely extraocular disease. And you can't stop with just the enucleation. It's necessary that you give adjuvant chemotherapy. Otherwise, it will just go back. Okay. A lot of patients, a lot of mothers, and maybe a lot more fathers are very worried about having I myself will not want my child to have his eye removed. But Look at this patient. Look at these patients. These are patients with artificial eye. If you look at them, maybe if you see them in the mall, you probably won't notice which eye is fake, which eye is still existing. Let me show you. Particularly on the left-hand photograph, you can see it's almost identical, but this is the affected eye. So this is what I show my patients. I show my parents. I show them how their child will look because they're devastated with the thought of their child having retinoblastoma, having a malignant tumor, risk for life. But sometimes they're even more devastated by the idea of how their child will look after surgery. And if they see this, then they feel much better. Okay, so we tackled a little bit of general retinoblastoma care. Again, as a summary, the age of retinoblastoma, they're usually found between 0 to 7, mostly seen in 0 to 3 years old. It may be unilateral or bilateral. The warning signs and symptoms that general ophthalmologists, pediatricians, family medicine doctors, barangay health workers need to see, look and detect leukocoria, squint or ocular misalignment, inflammation or bulging of the eye. And the quick test, office test that you can do is just a corneal light reflex, red-orange reflex, photo screening if you have a camera. Dilated fundus exam can be done by an ophthalmologist for you, and you have to insist on him doing that. And of course, if it's available, a Redcap. Treatment strategies. Again, our goal is saving the life. So you have eye removal, you have eye sparing techniques and chemo-assisted therapies. This retinoblastoma is a life-threatening disease, but with high survivals if it's caught early and treated properly. So again, let me reiterate that we need you, pediatricians, general ophthalmologists, general practitioners, family physicians, and barangay health workers to pitch in, and you really play a key role in detecting this tumor early. This is a poster that we sent in several centers showing the signs and symptoms. We have in Manila, we have government centers, the UPPGH, the biggest referral center for retinoblastoma. East Avenue Medical Center with Philippine Children's Medical Center is another big center that treats retinoblastoma. In Davao is very active with Dr. May Dolendo, the Southern Philippines Medical Center, a very active retinoblastoma center. Of course, we have private institutions, this Medical City, Manila Doctors, Makati Medical Center, PGH, of course. Yes, and St. Luke's, there are very excellent doctors as well that will be able to treat retinoblastoma. So that's it. Thank you very much for taking this time out to hear about retinoblastoma.
Thank you for that insightful lecture, Dr. Mercado. Before we proceed to our question and answer portion, let's have one of our panelists give her reactions and maybe introduce Dr. Gertrude Gwendale Baron Reynoso. She is a graduate of the UP College of Medicine and is practicing ophthalmology at the Asian Hospital and Medical Center and Las Piñas Doctors Hospital Eye Center.
Thank you for that warm welcome and kind introduction. Just a few comments about the lecture. Thank you, Dr. Mercado, for a very insightful and comprehensive lecture. The first thing I'd like to bring up is how common retinoblastoma is, although we don't have a high index of suspicion most of the time. Very often when we see a pediatrician examine a patient, most commonly the pediatrician would examine the ear and not the eye. Although they have the ophthalmoscope handle, I don't see them really carrying the ophthalmoscope head. So maybe it would be really good to emphasize the need for at least red reflex testing so that the so that the patient can be tested regarding the presence of leukocoria. And not only that, right now, I don't know if you're aware of the case where a patient was diagnosed with retinoblastoma just from a Facebook picture.
Mm.
There has been this celebrated case of a baby who had a holiday photo, and one friend who was from the other side of the world noted the white reflex, and true enough, the baby had retinoblastoma. So the social media can help a lot too. The other thing that I'd like to bring up is the um, multifactorial nature of retinoblastoma. Not only is there a somatic gene mutation, but there could also be a germ cell mutation. And I would like to ask how you would counsel these parents who have retinoblastoma children who are suffering from retinoblastoma. Would you tell them to undergo DNA analysis, and would you warn them not to have any more children? How would you go about that? And third is the multi-specialty nature of the disease. This is not just an ophthalmology problem. And, therefore, everybody should work together for saving lives, not just saving the globe, not just saving sight. How would you react to that, Dr. Mercado?
Yes. Let me tackle first the idea about the team effort here, and I agree with you wholeheartedly. As you mentioned, like the chemotherapy is not given by myself; it's given by a pediatric hemo-oncologist. So we work with them closely. We work with radiation oncologists as well, and we work with we try as much as possible to work with psychiatrists as well. But since these are small children, you know, because they might have some lifelong issues in terms of their appearance. Um, it's really a team approach, and to include also, again, I'd like to reiterate the primary care physician is part of that team as well. Now, you mentioned about about detecting by photographs. Yes, I have some patients that come into my clinic with a photograph showing me what they noticed, the white pupil. And usually that happens on their first birthday, when they have this special birthday and they have this photograph and they see that white pupil. Certainly, that's one of the clues. Unfortunately, yes, when you see those white pupil, that's kind of late already. And yes, it's I cannot blame or I can't, it's really difficult for non-ophthalmologists to do ophthalmoscopy, but yes, just doing those, we do remind and do give lectures to pediatricians and primary care physicians to do that corneal light reflex, just a simple test, just to check, so very easy.
And just to add to that, it's not just the leukocoria, the strabismus. You really mentioned that.
Yes.
You can actually catch earlier
Yes.
the disease earlier if you see strabismus.
Yes.
Unfortunately, in my practice, because I practice glaucoma, I usually see them very late already when they are anterior segment. There's anterior segment involvement. But maybe you can talk about the strabismus a little more. How to detect that? Swinging flashlight or cover uncover test.
So it's just to check for strabismus. A lot of patients, mothers, do bring their kids over, seeing that like suspecting that there's squint, or ocular misalignment. You just flash a light a little distance and you look at the reflection on the eye, on both eyes, and you see where it lands. And then you can cover one eye and cover the other and see that the eyeball doesn't move. Try to compensate. It should be a quick, using the flashlight, cover and uncover, and see that the reflex is still in the same spot. And it's really a quick test. I mean, we recommend this really for well baby clinics. We don't really suggest it during, newborn patients, of course. But of course, there are other things that you have to concern with newborns, but usually with well-baby patients.
Okay, and the last question was regarding genetic screening.
Yes, I don't bombard the patient or the parents at the first time they come to visit my clinic when I divulge that there's tumor. It's too much information for them. You know, they're so usually while we're doing the treatments, I start slowly telling them the bilateral disease or the multifocal unilateral disease are heritable, which means these can be passed on. We don't see a whole lot of patients that are survivors of retinoblastoma that are bringing their kids now yet, but they're starting to come because before a lot of patients did not survive. You know? So now a lot more patients are surviving. They're having their children, so they're having their comeback. So every time I have to reiterate to the parents, I don't tell them not to have babies.
Yeah.
Maybe that's not for me to say, but I do lay down the risks. If it's bilateral disease, of course, there's about 40 to 50% risk for the child. So if they decide to have children, I just tell them, just promise me, first month of life, I need to see the patient. So we might be able to still save the eye, and definitely save life. So.
Thank you very much.
Okay, before we proceed, there is one question from our listener coming from Dr. Pauline Santiago. How soon after enucleation can you do cosmetic rehabilitation?
Okay. Yes, Pauline, welcome. Yes, I usually have the artificial eye fitted after about 8 weeks from surgery. The conjunctiva or the wound would have healed by then. Of course, if it's a small baby, it continues to change. The change in the size of the artificial eye is quite rapid. So I don't recommend a custom fit artificial eye. So I just put in what we call RTW or ready to wear artificial eyes. But as they grow bigger, then we can do a better fit and it looks much, much better, of course. But about 8 weeks is the time that I have them be fitted with an artificial. Again, that's part of the team as well. We need a very good ocular prosthetist.
Okay, so there are no more questions fielded from the internet. So before we conclude, I'd like to give a summary of the discussions we have learned from Dr. Mercado and our reactor, Dr. Reynoso, the different risk factors for developing the disease, the signs and symptoms of retinoblastoma, how to screen properly to detect the disease, and how to do essential physical examination and what particular diagnostic tests we need to do, the different treatment modalities, and lastly, basically the goal of treatment, which is save life, save vision, and save the globe. So after this session, an email containing a survey link will be sent to you. And then after answering the survey, your certificates will be sent to you. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session. Thanks for joining us and hope to see you again in our upcoming webinars on March. For the first week the next webinar is entitled Work-Related Upper Extremity Pain with our speaker, Dr. Melissa Mercado, on March 30 at 12 noon to 1 p.m. Manila time. Please invite your colleagues to join this continuing monthly CME webinar series. All webinar schedules and resources will be posted at www.upm.edu.ph/UPMedwebinars. In behalf of UPCM Class 1991 and the UP Medical Alumni Society, we also thank our collaborator units, the UP Manila Information Management Service, the National Telehealth Center, the UP College of Medicine Postgraduate Institute of Medicine and Medical Informatics Unit, the DOST ASTI, and Ms. Charisse Orhalo, our host. This is Dr. Maki Filona together with Dr. Gary Mercado and the UP Med webinar team closing this session. We hope you have learned a lot from today's webinar. Join us again on March 30. Have a great week ahead.